Okay, well, we might make a start. More people will come on, I think, as we go. But welcome, good afternoon, everyone, and welcome to another week of teaching. I hope you've had a good week. And hello, Hicks and Matt. I can see you guys in NRH. Yeah. Hey, I'll just share my screen and I'll share my slides, and we'll make a start. Eh? Okay. Okay. All right. As I say, a few more people I think will come on as we go, but let's make a start. I'm sure you're probably quite busy too. Today I wanted to talk about dengue. This is I think it's the 31st week of teaching, and there's a few topics that we haven't covered, and I thought it'd be good to cover dengue because it teaches us actually a lot about virus infections and the way they affect the body, and because it's a common cause of fever in children, and it's part of the differential diagnosis of fever and rash. So there's lots of ways in which we can learn about, can understand things about dengue, and also it can teach us a lot about how, I'll just let a few people in, but it can teach us a lot about how we look after seriously ill patients, because we, patients who have dengue have quite complex fluid requirements, and it's good to have an understanding of the pathophysiology and immunopathology of dengue. So today, this is the plan. I think we want to learn about dengue, basic things about dengue. As I say, to understand the immunopathology, which just to be clear from the start, it requires an understanding of what's called antibody-dependent enhancement of virus activity. And we get used to the idea that antibodies protect us against infectious diseases, and they do. They're very important for protection, but sometimes some antibodies can actually enhance the nature of the infection, and that's why I wanted to talk about dengue in that context, the immunopathology. I want to be able to understand why there's vascular permeability in dengue, and to understand the I'll just let some more people in, understand the clinical signs and the differential diagnosis of dengue, because from a clinical point of view, sometimes dengue is obvious, but sometimes it can look like other forms of virus infections, or, hold on, I'll just admit some people. Sometimes dengue can look rather like other virus infections, and it's important that we that we have an understanding of the differential diagnosis, and to understand about fluid management and general supportive care. So I think to look after patients with dengue, we have to be really good at the supportive care of seriously ill patients, and understand the natural history of the illness and how it progresses from one stage to another, and not overtreat patients in early stages to make them worse. You will all know about the classification of dengue, and that is dengue. There's been several classifications that the World Health Organization has had, but this represents the most recent, the most current classification, and that is WHO separates dengue into that which is dengue fever, and then dengue fever with warning signs, and then severe dengue, and all the other things like dengue hemorrhagic fever or dengue shock syndrome, they're all just part of severe dengue, because in reality that there's so much overlap between all the different sorts of severe dengue that it's just put into one group called severe dengue. And our challenge is to understand to what degree a child's in shock, has hemorrhage, has edema, has fluid accumulation, etc. They're the challenges of looking after children with severe dengue, and the challenge of dengue fever is not to overtreat them and lead that, and for them to then get complications. And the challenge of dengue fever is to look out for warning signs that tell us the child's going to develop severe dengue. Not all patients do. Most patients, of course, don't develop severe dengue, but there are warning signs that indicate which patients are going to progress from dengue fever to dengue with warning signs to severe dengue. And then understanding the pathophysiology at all the different levels of severity is very important. With dengue fever, the incubation period, as you probably know, is around about 4 to 10 days from the time mosquito bites. Anopheles mosquitoes, the Aedes aegypti or Aedes albopictus are the main ones. And there's usually, to start with, there's usually 2 to 7 days of high fever, and often children have headaches and pain behind the eyes, or muscle aches and pains. It can look very much like influenza. Sometimes they have a rash, and sometimes they have nausea and vomiting, so gastrointestinal features. So just, as I say, just like a really bad case of influenza or a case of severe sepsis. The rash looks is often like any other sort of viral rash, like rubella or measles. It's an erythematous macular rash. Sometimes there's conjunctival. Rarely is there any respiratory symptoms. So one way to distinguish dengue from other sorts of viruses that give you rash is usually there's no respiratory symptoms. It's usually just fever followed by the rash and systemic features. But there are other types of acute viral syndromes that don't have respiratory symptoms. So there is still a differential diagnosis to think about. This is the type of rash. So these are 2 children with dengue, and you can see it's an erythematous maculopapular rash that you could see in many different sorts of illnesses, such as measles, rubella, streptococcal infection, that sort of thing. If a patient progresses to severe dengue, then usually they have developed these warning signs somewhere between 3 days to a week after the onset of their fever. And the warning signs, I'll go through them again later, but often they develop severe weakness, abdominal pain, persistent vomiting, rapid breathing, sometimes bleeding from their gums or bruising on their skin. Sometimes if they've had a lot of vomiting, they'll have blood in their vomit. So it's really worsening of their gastrointestinal features, the appearance of hemorrhage in some way, and sometimes the appearance of edema or general body swelling. They typically at this stage start to have a severe capillary leak syndrome, where they'll have fluid accumulating in both the tissues, in the lungs, sometimes in the pleural spaces and in the peritoneal cavity. And because of that, they often have respiratory distress, and that goes along with sometimes multi-organ dysfunction, hepatic dysfunction, or kidney dysfunction. Usually at this stage, by that stage, when children have severe dengue, their hematocrit's going up because they're leaking a lot of fluid from their intravascular space into their interstitial fluid, into interstitial tissues, and so they're becoming more hemoconcentrated. Their platelet count's going down. Sometimes their liver transaminases will be going off. That is, they get a rise in their ALT and their AST, and usually their albumin is going down because it's a negative phase reactant. Often their albumin is going down. And sometimes it'll be leaking into the tissues as well. By that stage, they often have a very narrow pulse pressure. And this is the key feature of severe dengue, is that unlike other forms of sepsis, where I'll just have to admit some people, but unlike other forms of sepsis where there'll often be bounding pulses and vasodilatation, in dengue, typically it's capillary leak with leakage of fluid from the intravascular space into the interstitial space, and a hemoconcentration of blood, so the hemoglobin goes up and the pulse pressure narrows, and then typically they become hypotensive. But this narrow pulse pressure is a very important early warning sign, and that's why when we're teaching people to monitor the blood pressure, we need to be teaching them about the systolic pressure, the diastolic pressure, and the pulse pressure. All right, that they really should be looking at the pulse pressure. It's very important. And sometimes they have gastrointestinal hemorrhage. Now, not all children with severe dengue will have all of these manifestations, but these are the manifestations of severe dengue, and many children will have a number of them. There is a tourniquet test that you can do for dengue. And what that typically tells you is that the platelet count's low. We can, of course, measure the platelets, but if you inflate a blood pressure cuff to somewhere between the systolic and the diastolic pressure and leave it for 5 minutes, then you'll see petechial spots. This is in the cubital fossa. You'll see petechial spots on the skin. And that usually tells us two things. One, that the capillaries are very friable because of the effect of dengue on the endothelium of the blood vessels, and also because the child's typically got thrombocytopenia at the same time. So it's that combination of capillary fragility and thrombocytopenia that leads it to a positive tourniquet test. And it's not uncommon in children with dengue to see their whole arms bruised because of this phenomenon of capillary fragility and thrombocytopenia. It is non-specific though, so you can get it, for example, with meningococcal disease or other forms of severe haemorrhagic disease. I wanted to talk about the immunopathology of dengue, because I've just spoken about the clinical features, but to understand why the clinical features exist, it's useful to know what the dengue virus actually does to the body and how the immune system reacts to dengue. And as you know, all viruses, they have to enter into cells to replicate. Otherwise, all viruses, whether it's influenza or RSV or COVID virus, they have to enter into the cells to replicate. And they use the host machinery, the organelles, the endoplasmic reticulum, the mechanisms of protein synthesis, the ribosomes in the cell. They use them to make new viruses. And in some ways, it's the ease with which a virus can enter the cell that determines the amount of viral replication. And so if there's, as you know, for example, with COVID, the virus enters the cell, and probably the Delta virus can enter the cell a bit quicker than the alpha form of COVID. And dengue is a bit the same. Sometimes dengue, with the first episode of dengue, then the virus is a bit slower to enter the cell than with subsequent episodes of dengue. And there's a good reason for that. But when the virus enters the cell, it uses the virus protein synthesis to replicate, and then more virus is released. When dengue infects a person, it enters the cell and it generates an immune response. And the immune response is twofold with dengue. One is that there are protective antibodies. And just like with all viruses, with measles or influenza or RSV, the body makes protective antibodies that combine with the virus and encourage the immune system to kill the virus, either through complement or through neutrophil or macrophage phagocytosis or filtering out in the spleen. So the fact that the virus combines with antibodies means that the immune system can do a much better job. And the same is true of dengue. There are neutralizing antibodies that are generated to dengue that enable the immune system to get rid of the virus. But there are also some other sorts of antibodies, and these are non-neutralizing antibodies. They combine with the virus, but they don't have the effect of enhancing the immune system to deal with the virus. But what they do have the effect of is enhancing the ability of the virus to get into the cells. And this is what the key thing about dengue pathophysiology is. There is something about the antibody response to dengue, because it's twofold. It's both neutralizing, but it's also enhancing. And usually with the primary virus infection, then there's normal virus replication. The virus gets slowly into cells and replicates, and it's usually quite low level. But when you've got a secondary infection in the presence of those antibodies, either from a child who's had dengue before and they've mounted an antibody response to it, or an infant whose mother had dengue, and the mother has given the child, through transplacental spread of antibodies, transplacental transfer of antibodies, has given the baby some antibodies. And if they're non-neutralizing antibodies, then that can enhance the entrance of the dengue virus into cells. So, and that can lead to somewhere between a 40 and 100-fold increase in viral replication. And that's one of the reasons why the second episode of dengue is so much worse. There's enhanced disease severity because of increased virus entrance into the cell because of these non-neutralizing antibodies. And so that's the immunopathology of dengue, and important to know. So as well as antibodies, that's the humoral immune response. There's also a T cell immune response. And remember, the immune system has several parts. There's the humoral immune system, there's a T cell immune system, and then there's the innate immune system, which is like neutrophils and phagocytes and that sort of thing. But when after the first episode of dengue, there is T cell activation. And as you know, the T cells become like killer cells or memory cells. And when there's another episode of dengue, then those T cells are activated, and they can produce an enhanced, what we call cytokine or pro-inflammatory response, where there's lots of cytokines. They're just chemicals that are released that cause fever and inflammation. Right? Whenever we get an infection, we're producing cytokines, and if we get a very bad infection with sepsis or septic shock, then we're producing a lot of cytokines. And with dengue, especially with the second or third episode, then there's a lot of these cytokines, especially interleukin-6, which is a cytokine that causes a lot of inflammation. I'll leave it at that, but there's a lot of different things that happen with the second episode of dengue, including enhanced cytokine production, reduced antiviral production, so reduced interferon, and sometimes enhanced complement activation, which means that there's just a lot more inflammation going on when you've got a second episode of dengue. So all of that inflammation leads to increased capillary permeability, and it's the capillary permeability that leads to the swelling, the edema, the drop in albumin levels because the albumin leaks out into the tissues, hypovolemia, which means there's a low intravascular volume because the water, the plasma is leaking out into the tissues. That leads to the hematocrit being high because there's hemoconcentration. So the red cells stay in the blood vessels, but the fluid leaks out. And because the fluid leaks out, it leaks out into the tissue spaces, which are like just the arms and the legs, but also into the pleural cavity and into the peritoneal cavity. And that's why you can get pleural effusions or ascites. And the major cause of this is a component of the virus called NS1, or it's called non-structural protein 1. And simply put, that's the protein within the dengue virus that produces this enhanced inflammatory response. Right? I won't go through it again, but it produces an enhanced antibody response, an enhanced T cell response, an enhanced cytokine response, and all that leads to the breakdown of the endothelial barriers, like the capillary barriers, and then you get leakage of fluid outside the capillaries. So it sort of all makes sense if the clinical picture of dengue that goes from dengue fever to warning signs to severe dengue with hemorrhagic shock. It sort of makes sense if you understand the immunopathology of dengue and the way the virus is only mild if you've never had it before. But if you've had it before and you've got a memory immune response, then it can be more severe, and then it goes away. Because usually when this cytokine or inflammatory response is on, then the virus is actually not much present in the body. It's not the virus that's causing the sickness by this stage, it's the body's immune response to the virus. Just like all viruses, the virus comes and goes, and it's usually when it's going, when the fever's starting to drop, then you get the severe inflammatory cytokine response. And so who's at risk of getting this severe dengue? Well, as I said to you, if you've had an episode of a child or an adult or an adolescent who's had a previous episode of dengue, especially if they encounter a second type of dengue. There's 4 serotypes, as you know, and if they encounter a second type of dengue from what their primary infection was, then they're likely to get a more exaggerated immune response, and they're likely to get severe dengue. Or a child whose primary infection, the child's getting a primary infection, but they've got antibodies from the mother. And it's those antibody enhancement that can lead to more severe infection in young infants, typically around about 6 or 7 months, because the neutralizing antibodies have fallen to certain levels. Like, as you know, if you get transplacental antibody transfer of any sort of antibodies from the mother, whether it's the RSV or hepatitis, for example, those antibodies, the maternal antibodies drop, measles antibodies drop over the first sort of 4 to 5 or 6 months. By 5 or 6 months, there's not much in the way of antibodies left. So all those protective antibodies will be gone, but there may be some non-neutralizing antibodies to dengue that can enhance the viral replication. And that's why infants in the second 6 months of life are likely to have a worse bout of dengue, or children, older children who've had a second episode of dengue. And as I said, the enhancement of viral replication is somewhere between 40 and 100 times, 100-fold, if you've had a previous dengue infection. So how do we look after patients with dengue? Well, it's very similar to any seriously ill child. And first of all, we need to just think about the stages of management of any child. And that goes for whether the child's got dengue or severe pneumonia or severe gastroenteritis with dehydration or severe malaria. That if you go through these stages, then you'll know that every step has been done properly. So a patient needs triage, and then if they've got emergency signs, they need emergency treatment. Then you should take a history and do a full examination, and then laboratory investigations if you need to, and there are some with dengue that you should do, and then come up with a main diagnosis and think about the other differential diagnosis that you should think about with dengue, and then decide on the treatment and supportive care and monitoring. Those 3 things are very important in dengue. The supportive care and monitoring is very important. And then understand what the natural history of dengue is, and think about discharge planning, like when is it safe for this child to go home, and what does the child need to achieve or do before going home. And then think about follow-up, because some children who've got severe dengue need follow-up. Right? And so in the triage, we should do the same thing as what we always do, and that is take a brief history of the presenting problem, take the child's temperature and get the weight. And then all of the dengue warning signs or the signs of severe dengue are included in the triage in looking for emergency signs. So we should look for stridor or obstructed breathing. That's very uncommon in dengue, but that's part of standard triage. We should look for cyanosis and check for signs of respiratory distress, such as chest indrawing or tracheal tug, and check the oxygen saturation. If we do that every time for a child who has signs of serious illness, then you'll get good at it, and it won't take you too long. And then very importantly, in a febrile illness that might be dengue, we need to check the cardiovascular system. And remember, I have said that you should feel the hands and the feet, and feel the skin temperature of the hands and the feet, feel the pulse volume, because when you're feeling the pulse volume, you're feeling actually the pulse pressure. And you should measure the blood pressure and learn what a narrow pulse pressure feels like and what a wide pulse pressure feels like. We should do that regularly so we get good at understanding what the pulse pressure is like, and then check the capillary refill time. If you do those 4 things, the skin temperature, the hands and the feet, feel the pulse, check the capillary refill time, and measure the blood pressure, just 4 things, you'll have a very good understanding of the child's circulation. And then you assess for lethargy and the level of interaction. And so that's triage. And if you get good at it, you'll be able to do that within a minute or 2 of a child presenting. And then you'll know if the child's got any emergency signs that need emergency treatment. Okay. If the child's got any emergency signs, or they've got any dengue warning signs, which are abdominal pain, like in the early stages, because often in dengue that where there's accumulation of fluid, then the liver will become big, and that can cause abdominal pain. Or sometimes there can be ascites or congestion of the bowel, and that can cause abdominal pain. So any child with dengue who's got abdominal pain or persistent vomiting or edema or respiratory distress or any signs of bleeding or bruising or petechiae or lethargy or oliguria, or if the hematocrit is high or the platelet count is low, then they've got early warning signs and they should be admitted to hospital for monitoring and for supportive care and treatment as needed. All right, so they're the patients with dengue that you should bring into hospital. We should also think that a child who looks like dengue might have something else, and it's very important that we look for other causes of fever and rash or high fever, such as malaria, but it could be measles or rubella, or there's some other viruses like influenza or adenovirus or enterovirus. They can all cause a fever and a rash. Now, we can't always test for those viruses, but we need to think about them as part of the differential diagnosis. And many children with dengue, if they've got warning signs or they've got severe dengue, then they look like they might have bacterial sepsis. And it's important that we also look for that, take a blood culture if you can, and start them on antibiotics for bacterial sepsis. Some children with dengue look like they've got typhoid. They might have a rash, a bit like typhoid, or they might have some other arboviral infection like chikungunya virus, which gives you a systemic viral infection with a fever, or COVID-19. There is that MISC, the multi-system inflammatory syndrome, that can look a bit like dengue. And children with MISC have a high fever and a rash, and they have mucosal involvement often. And so all of these are part of the differential diagnosis of dengue. And we just need to think about what else could be going on. There are some investigations that you can do, and I think we always do a full blood count, and in dengue, the features are a high hematocrit, often leukopenia, that is the white cell count will often be low, and the platelet count will often be low. If a patient doesn't have those, it doesn't mean it's not dengue, but if they do have those, then it means they've got dengue of a severe nature, and those children should be admitted to hospital for sure. We can look for dengue virus on PCR, the polymerase chain reaction, looking for dengue virus antigen, and sometimes there are some tests that look for the viral antigen, the viral antigen that causes the severe capillary leak. There are various ELISA assays that look for PCR or the viral antigen. We can also look for dengue virus serology. So that's the antibody. IgG will be common, but IgM is often, it's not a very good test because often it is late. So the child will be in the convalescent phase before the IgM is positive. So it's not such a good test. Sometimes the albumin level will be very low. So if you do the liver function test, then typically the albumin level will be low, and sometimes the ALT and AST will be high. Many children with dengue or any of the other differential diagnoses have a metabolic acidosis, like they'll have a low bicarbonate and a low pH. And so sometimes that can be useful in assessing the severity of the child's illness. And then look on the chest X-ray for signs of a pleural effusion or signs of pulmonary congestion, etc. So there's some investigations that you can do. The only ones, usually we diagnose dengue clinically or with viral PCR or the antigen test, all right? And the full blood examination can be useful. As I said, the phase of dengue, the phases are, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, 102, 103, 104, 105, 106, 107, 108, 109, 110, 111, 112, 113, 114, 115, 116, there's three major phases. One is just a febrile phase where it's just dengue fever, but the child during that time might have some warning signs, but often the temperature is very high. So this is the fever, and it can last for 3 or 4 days. And usually it's gone down before the more severe phases occurred. But in that time, hi, it's Trevor Duke speaking. Yes, Jeff. Yes. Yes. Oh, yes. Yes, no, are you in the unit at the moment?
Yeah, I'm actually in the cath lab. So.
Oh, okay, no, that's right. Look, yeah, no, there is. I mean, John Vrazis has been involved, and Elhaney have been involved, and they're, you know, they were making a plan with Igor. So, I mean, it's good to hear your opinion, but perhaps we all should get together when you're available and talk about what the best way to do it is. There's Igor has said he'll take him to theatre at some point in time, but I think before that there was going to be further discussions with John Vrazis and Elhaney. Yes. Okay, well, maybe we should all discuss with Igor at some time soon. When will you be available? Okay, I'll see you then. If you can come up to the unit, we'll talk about it then. Thanks, Jeff. Bye. Bye. Sorry, everyone. Okay. Yes, in the early stages where there's where the temperature is high, often the child, because of the high fever, the child will often get dehydrated, and sometimes that capillary leak has started, and so the hematocrit will start to rise. During that time, that's when the virus is most active in the body. It's when the child gets to a more critical stage, and not all children do. Most children don't. They get over, after their viremia, they're over their dengue. But for those children that get to a critical stage, that's when often the fever is resolved, the hematocrit starts rising, their viremia is largely resolved, and that's when they get the coagulopathy, the platelet count falls, and they get fluid collecting in their pleural space and in their tissues. And then by that stage, most of the virus is out of their system, and it's all the immune system being very active. And then the last phase is important. It's the recovery phase, and we need to understand when the shock phase is finished and when the recovery phase is starting. Because if we don't understand that, then what we end up doing often is fluid overloading the patient. And there's a period of time when we need to treat their shock, and then there's a period of time when we need to back off on the fluid management, the fluid giving fluid, and make sure that these children don't get too fluid overloaded. And knowing when those phases occur is very important. Many children never get past this just febrile phase. They just get the fever, the viremia, and then they get well. Okay, I'll keep going. This is the sort of chest X-ray of a child. This is a chest X-ray of a child with dengue, and you can see how much there's a pleural effusion of a large degree. And this is typical with children with quite severe dengue, that a pleural effusion is relatively common. This is another child who's also got dengue who has a right-sided pleural effusion. And sometimes there's a bit of inflammation of the liver, and fluid tracks up through the diaphragm into the right pleural cavity. But you can see two things about this X-ray. One is that there's a right-sided pleural effusion, but also the lungs generally look wet. And that's because there's capillary leaking fluid into the tissues. So this is a child who's at the at the end of the critical stage, or in the early stages of the recovery, where there's low albumin levels, there's fluid leaking into the tissues, etc. So the treatment, I've talked about the different phases, and the treatment is different at different phases. And this is very important, that we understand the phase the child's in and whether or not the child's progressing from the febrile phase to the warning sign phase to the critical phase to the recovery phase. And in the early phase, for most children with dengue, they just need analgesia and they need a daily review. Like, they don't all need to come into hospital. If they've got no warning signs, then most children with dengue can be managed at home if they don't have any warning signs. But they should be seen every day, just to make sure they're not developing any other features. It's best not to give aspirin or non-steroidal anti-inflammatory drugs, because they can increase bleeding risk, because they'll impair platelet function. All right, so paracetamol's fine, but not aspirin in children with dengue, or not Nurofen, ibuprofen, or indomethacin. Don't give those drugs to lower the fever, because they may increase the bleeding risk. You should review them every day. In severe dengue, then most of the treatment is about supportive care. So analgesia with paracetamol, fluid management, and respiratory and circulatory support. So sometimes these children need extra fluid, sometimes they need oxygen and CPAP. They often need just simple analgesia. And most of the treatment is just supportive care to make sure their circulation is okay, their respiratory function is okay, and to get them through to the next phase, and to reduce the chance that they'll get complications. So the complications we're looking out for are shock or bleeding, or pleural effusions, or pulmonary congestion, or liver or kidney dysfunction. They're the main complications of dengue that might occur in that critical phase or in the early part of the convalescent phase. The fluid management depends on the phase, and so in the early phase with fever, just oral fluids is fine, and avoiding dehydration. In the severe phase, if they've got warning signs, or they've got edema, or they've got any signs of severe dengue, then they'll have plasma leaking out into the extravascular compartment, and they do need some extra fluid, especially if they've got a narrow pulse pressure. And WHO says if the pulse pressure is less than 20, then they should have additional fluid, because they're in shock. If they've got a coagulopathy, then sometimes giving fresh whole blood or plasma is useful. Generally speaking, you don't need to do that. You just need to replace their plasma volume with a isotonic fluid. Like I typically use Hartmann's solution to do it, would be fine. Or if you've got albumin, you can use albumin, but mostly that's not available. In the convalescent phase, the most important thing to do is to know that when the transition has occurred between shock and convalescence, because by doing that, we can know when to stop giving too much fluid. And the cardiovascular examination, those things that I mentioned at the start, feeling the hands and feet, feeling the pulse pressure, looking at the pulse pressure from the blood pressure, and looking at the capillary return, that can all help us understand when the child's transitioning from the acute critical phase to the convalescent phase, and monitoring for those fluid accumulation complications is very important. So in shock, dengue shock, you should use an isotonic fluid, and you should give fluid until the capillary permeability is back to normal. Because if you keep giving IV fluids, then the patient will often be fluid overloaded, and you'll worsen their pulmonary congestion, you worsen their pleural effusions, worsen their ascites. And so if they've got a normal pulse pressure, they're not in shock, don't give them extra fluid. But if their pulse pressure is less than 20, then they need some extra fluid. So give 10 or 20 mils per kilo over an hour, and then reassess their circulation in the way that I described. If they've got bleeding or shock, then give whole blood, because that also has plasma in it. And if they've got a platelet count less than 50,000 and they're bleeding, like they've got bruising or petechiae, then I keep their platelet count above 50,000. If they've got no bleeding at all and their platelet counts drop to below 5,000, then certainly I generally give them platelets if you can, because that will prevent bleeding, because there is a risk of severe bleeding from the gastrointestinal tract, for example, in children with dengue. I've talked a bit about the pulse pressure today, and I think this is very important to know what the normal pulse pressure is at different ages. Like I said, that if the pulse pressure is less than 20, then the child's in shock with dengue. And this is the normal pulse pressure in children at different ages. And I think we should be focusing a bit on this, because whether it's a child with sepsis or anemia, they'll often have an abnormal pulse pressure. If they've got hypovolemia, they'll have an abnormal pulse pressure, and it may be either narrow or it might be wide. And by understanding what the child's pulse pressure is, that difference between the systolic and the diastolic pressure, it can tell us a lot about the state of the child's circulation. So this is the normal range of pulse pressure. And if you see a child like a school-age child who's got a pulse pressure of 25, then you know that's a very narrow pulse pressure. And there's only a certain number of things that can cause that. Or if you see, for example, a child with a pulse pressure of 70 or 60, then you know that's a wide pulse pressure. And there are a certain number of things that cause that. And so I think when as part of a clinical skill and teaching others about the cardiovascular system, we need to be measuring the blood pressure and looking at the pulse pressure a bit more. I'll send this around so you know what I'm talking about, but we can, yeah. I think these patients should be monitored. Any patients with warning signs should be monitored very closely in an intensive care unit or a high dependency area. And they should be monitored with a monitoring and response chart, a color-coded monitoring and response chart that can monitor their temperature, their respiratory rate, their oxygen saturation, their degree of respiratory distress, their heart rate, their blood pressure and their pulse pressure, and their conscious state and the treatments that are given. So using a monitoring chart like this can really help you understand whether the child's going in the right direction or going in a bad direction. In the convalescent phase of dengue, then it's really important that we manage these patients properly and stop giving them intravenous fluids and stop causing fluid overload. And sometimes by this stage, children have needed some oxygen or positive pressure support. And sometimes they will need some diuretics, some frusemide to get rid of some of the fluid. But you really shouldn't give frusemide unless the child actually, if the child's in shock, don't give frusemide. But once that shock state is resolved, their pulse pressures return to normal, or if they've got very wet lungs, then it's okay to give them some diuretics. So it's all about understanding their cardiovascular state, their respiratory state, and the interaction between the two, and what that means for the different phase of illness that the child's in. I'm about to finish now, but there is some interesting things about COVID and dengue, and throughout Asia, there's been, because COVID's been going for so long, there is been some cases reported in Thailand, Singapore, where there is some cross-reactivity between COVID antibodies and dengue. And so if you see a child who's got dengue, you should also test them for COVID PCR as well. I won't say any more about that, but the two conditions have some similarities in terms of their multi-system, the multi-system nature of their illness. And so this is something just to keep in mind. And I won't talk too much about this today, but for some of you will know there was a trial of a dengue vaccine done some years ago, especially in the Philippines, and that wasn't very successful because when you mount an immune response to dengue, it depends what sort of immune response you mount, but sometimes that can be like a helpful response, and sometimes it can be a not so helpful response because of what I mentioned. And that vaccine trial wasn't successful. but there are new vaccines out for dengue, and they seem to be more safe and more successful. So we'll hear more about the new dengue vaccines. But one of the most exciting things about control of dengue has been this project where there's a bacteria inserted into Aedes aegypti, mostly Aedes aegypti rather than Aedes albopictus, but a bacteria called Wolbachia. And when Wolbachia infects Aedes aegypti, then they become resistant to dengue virus. And it's a very exciting thing because it rather than a vaccine that prevents dengue in the population, this is like a vaccine or an intervention for mosquitoes that will actually reduce their potency for becoming infected with the dengue virus. And it's not just theoretical. It's been this, you might know about this, but this project has been run very successfully in several countries in Asia now, and shown to reduce the burden of dengue fever. And so this is probably the most exciting thing in terms of dengue control around the world at the moment. And there is some experience of it in PNG, and there's certainly a lot in Indonesia and in other Asian countries. Anyway, today I really wanted to just take you through the clinical aspects of dengue and go through dengue fever and dengue with warning signs and dengue shock syndrome, and probably demonstrate how the clinical features can be explained by the immunopathology, and how we have to understand that to really treat patients well. And know that dengue is a self-limiting virus. It's self-limiting. Most children get better from it, but we have to understand the stage the child's in and the degree of treatment the child needs to treat them properly. So that's all I want to say today. I hope that's been useful, but we haven't talked much about dengue throughout the year, but I thought it would be useful just to cover dengue. I'm going to stop the recording now and